Good evening, everyone. I hope you find the sessions useful. I would suggest if you have any questions, you can email it to the support team and I can respond and they can share it in your group. In terms of today's topic, it's very important topic for all of you. It's an overview of the care of the premature baby. I don't know how many of you will be working in full-fledged NICUs, but obviously having a knowledge of all the aspects of prematurity is very important. Of course, this is not exhaustive. It will not cover all the aspects in detail, but this will give you a good summary of what you expect. So we will proceed with it. We have one important topic coming up next week, which is respiratory distress in newborns. So we'll be discussing the scoring of respiratory distress, assessment, and some details of individual causes. We will soon have an interactive session on management of respiratory distress as well, where we will discuss a brief overview of how we approach babies with that. So just to start off, prematurity is basically birth under 37 weeks of gestation. We discussed the definitions in one of the previous sessions as well. And we know that there are recent advances which have improved the outcomes even in the extreme premature babies. Of course, this depends a lot on where you work and what facilities available in your unit. In a developing country like India, there is wide variations in options available. There are level 3 NICUs which are equal to those in the Western countries, and there are also basic NICUs which struggle to manage non-invasive ventilation even in bigger babies. Infection rates are higher, and affordability of care is also a limitation in the developing countries. So in this presentation, I'll discuss the course of a premature baby in the NICU to illustrate various problems and some common questions that come up. So we have a mother who presents to the obstetric unit along with her husband. She is primigravida. The pregnancy is uncomplicated so far. She is now 26 weeks pregnant, and she has been noticed to have like a draining. It's clear, and there are some contractions as well. When the obstetrician assesses the confirmation of a preterm premature rupture of membranes, and she's in early labor as well. Because she's 26 weeks, she's in early labor, there is no risk of infection. The obstetrician gives her tocolytics mainly to get time for the action of dexamethasone. So she gets the steroid, which in that unit is dexamethasone. Many of you may be using betamethasone, which is acceptable practice as well. So according to where you work, either beta or dexal can be given. Antenatal steroids have an interesting history, though in the early 1970s, we had clear evidence from Dr. Liggins and Hovey's study that it's very effective to reduce RDS in preterm babies. It's widespread use took another 15 to 20 years. And this delay is the main reason why the Cochrane neonatal group was set up to make evidence-based medicine more widely available and to start implementing such research evidence fairly quickly. If you look at the symbol of the Cochrane group, it's basically the forest plot for this particular meta-analysis on antenatal steroids, and the first study in that is from Dr. Liggins and Hovey. The antenatal steroids work by stimulating the release of surfactant, which is stored in the lamellar bodies in the type 2 pneumocytes. It also stimulates the messenger RNA and thus helps fresh production of the surfactant by the type 2 alveolar cells. It has a stabilizing effect on the cell membranes, and it reduces the severity of lung disease. When the lung disease is less severe, there is more hemodynamic stability, and this leads to less IVH and less hypotension and complications similar to that. That is the reason we get benefit not only on RDS, but also on IVH, NEC, and other complications of prematurity. And either betamethasone or dexamethasone can be given as intramuscular injection. Some studies give dexamethasone splitting as 4 doses, while others will give 2 doses similar to betamethasone. The reason for giving this dosage is mainly because of the half-life. Typically, it's used after 24 weeks, but in some Western countries and where the outcomes of 22 weekers is increasing as well. So 22, 23 weekers is a consideration for giving steroid as well if they have impending preterm labor. The onset of action occurs within the first few hours of the dose, but full benefit takes 24 to 48 hours. So if there is chance to give it early, when you anticipate that she's progressing, you give it. But again, you have to balance it because you cannot repeat the dose unnecessarily. And even one single repeat is controversial. Previously, in the early 90s to late 90s, there were many studies which looked at repeated antenatal steroid doses at weekly interval in twins and so on. They found that the repeated doses had side effects on the fetal brain as well as the fetal lung maturation. So it doesn't help and it may harm. So there is some consideration for a repeat course if there is impending delivery 3 weeks after the first dose and the mother is still 32 weeks and below. So where you gave the first dose of steroid, she didn't deliver, and then after 3 to 4 weeks, she is going into preterm labor still below 32 weeks. You may consider giving a repeat course, but that's only one single repeat that can be given. So the first dose should be chosen with care when to give it and in whom to give it by the obstetrician. Keeping this in mind, they shouldn't rush to give it just because it's a twin and they reach 28 weeks or something like that. If she's in active labor and you really think she's going to deliver, you give the steroid. There is some evidence that it can be used in 34 to 36 weeks. There was an ALP study from US and some guidelines were modified. But still there is controversy whether we should really use in the babies above 34 weeks because the RDS is not that severe, and as the baby gets bigger and we have more sophisticated management in the NICUs, the outcome is good. So we don't need to give a medicine which could potentially be toxic. And in elective LSCs in term babies as well, the same ideology is coming up. So there are two groups. One may believe in giving it and one may believe in not giving it, because there is a study on neurodevelopmental outcome of the babies who received steroids at early gestation, but they didn't deliver preterm. They went on to deliver term. And the babies who received steroid have a poorer neurodevelopmental outcome. This could be because of the reason they received steroid in the first place, but it's not clear cut. So if you feel it's not to be given, it's fine as well. So we discussed the benefit already, reduces the severity of RDS. There is improved survival and reduced IVH as well. The illness severity and overall hemodynamic stability may contribute to the non-respiratory benefits as we discussed earlier. So the neonatologist met the couple in question and they explained the prognosis at 26 weeks and the expected course and problems related to prematurity. So communication is a very important skill. And in these highly stressful situations where there's a lot of uncertainty, we need to be clear about what is important to communicate at that particular time, not to overload with information. At the same time, be clear, be inclusive. So give them the option to decide where there is an option. But in most units, 26 weeks is not a question of, it's not a gray zone. If your unit can manage such babies, you manage them or you stabilize and transfer them. So they also briefly discussed the problems related to prematurity. At this stage, you would not make them more anxious by giving too much information, but you have to summarize there is a high risk of infection at any time. The baby needs to stay for 2 to 3 months in the NICU according to the gestation. You can mention the complications related to feeding. You can stress the importance of breastfeeding. Remember that the mother has to start expressing soon after delivery. So to get her cooperation, she needs to know the importance of breast milk for such babies, and it's a good time to mention that as well. So in terms of survival and neurodevelopmental outcome for extreme premature babies, it has been constantly improving in the past 10 to 15 years. So the initial data we had was the Epicure study, which was done in the late 90s. Then we had the Epicure 2 study, and we have long-term neurodevelopmental outcomes. And of course, we have the NIH study from US, and the Vermont Oxford keeps giving us regular information as well. So we can monitor those to know. So the survival rate at present in most of the centers, it's 5% at 22 weeks, though some centers boast 40 to 50% of admissions at 22 weeks. Not all the babies at 22 weeks survive to admission. So we have to look at the statistics carefully, whether they're talking of all 22 weekers delivered or among the 22 weekers who got admitted. It's a 30% survival at 23 weeks, 50 to 60% at 24 weeks. And 65 to 75% at 25 weeks. So remember that this keeps changing, and it also depends a lot on where you work. So this statistic may not apply to most of the units in India, where 25 weekers and below may be out of their scope. You may be looking at 26 and above. Among the survivors, the neurodevelopmental outcome, there was no disability in about 50%, severe disability in 23%, and other disability in 25%. So some form of disability in close to 50% and no disability in 50%. This is for the babies at or below 25 weeks. And beyond 25 weeks, there was 80% survival at 26 to 27 weeks. And at 28 and above, we get 90% survival. But this is in the best of the settings. In the resource limited settings, it may be lower than that. So you should familiarize yourself with what the survival rate is in your unit or in your region. And of course, strive to achieve that. I mean, we have benchmarking data, you get your unit survival. And when you start managing small babies, there is always a learning curve. So you may have more difficulty. Your team has to get familiar with managing the small babies. So you have to put in a lot of time and effort to improve the quality of care delivered. You learn from mistakes. You have to educate the whole team. Having a stable team helps a lot. So try to retain your staff and try to do your best to manage such babies. Developmental outcome improves progressively with gestation, and most of you are familiar with kangaroo mother care and development friendly supportive care for the babies, so that's important as well. In this case, the labor stabilized with the tocolytics. She did manage to receive 2 doses of steroid. She went into labor again. The tocolytics are stopped after the dose of steroid is delivered and the effect is there. So she delivered after 3 days and by normal delivery. The baby was 26 plus 3 weeks by that stage and birth weight of 1.1 kilo, which is appropriate for gestation for 26 weeks. The baby is delivered into plastic bag. The reason the baby is delivered into plastic bag is to maintain the insensible, reduce insensible water loss and to help manage the temperature. The cord clamping was delayed for 40 seconds. That's because the labor room was not that warm. But if you keep at 25-26 degrees, you can wait for 1 minute if the cord pulsations are good. So this is the plastic bag. You can use non-sterile plastic bag which has been used to ethylene oxide sterilization. Gas sterilization is possible, and you can use those bags. And when you cover the baby with the plastic bag, whatever is evaporated, so you won't dry the baby after delivery. You just trap the baby in the plastic bag, and whatever water vapor evaporates, because the baby is under the radiant heater as well. So the evaporation will be confined to this plastic bag region. So the relative humidity goes up to very high levels, and the heat loss from the baby by evaporation is stopped. So when the insensible water loss stops because the relative humidity is high, there is no barrier, I mean, no gradient for further evaporation. And so the temperature is maintained. So in a very small baby, having a high humidity is one of the main mechanisms which helps to maintain the temperature. Delayed cord clamping is also very important in the premature babies. We discussed it in the last lecture as well. So delayed cord clamping is basically blood should be within the baby's lungs. In utero, the lung doesn't do the breathing, so it's going to the placenta. And after the placenta function is finished, after delivery, this blood needs to come back into the lungs, and that will only happen if you delay the clamping and wait for the lungs to open up. So it's more beneficial in the premature babies because if this blood doesn't come, the circulating blood volume for the baby will be reduced, the oxygen carrying capacity will be reduced, and the baby is more prone for hypotension, shock, and IVH as well. So the cord clamping is delayed for 30 to 60 seconds. If the cord pulsations are good, your obstetrician may be worried that the premature baby is not crying. You don't expect them to be vigorous and cry soon after birth like in a term baby. So even if the baby is not active and crying, you can wait if the cord pulsations, which indicates the heart rate of the baby, is good. So there is no bradycardia, there is no asphyxial risk, and it's okay to wait. And this benefit is going to be much more. There is also immunoglobulins from the mother, which was transferred to the baby through the placenta. And the baby should be held at or slightly below the maternal pelvis. The only disadvantage of delayed cord clamping is a slightly higher incidence of jaundice, but this is not a major disadvantage because these babies are anyway in the NICU and you'd be treating them with phototherapy. So this is the tiny 450-gram premature baby intubated, and you can see how small the baby is. This bruising is common. Previously, we used to say baby badly bruised, don't resuscitate, but it doesn't have a direct correlation. Because their skin is so fragile, just the delivery process bruises them, so that doesn't mean they're not viable. The eyes are often fused, so this baby is about a week old, so they started to open the eyes, but eyes are often fused, and you know the body fed Ballard scoring. When you do that, Most of the scores are minus in this case. The baby needed some positive pressure breaths. Then there was a good heart rate and respiratory effort, but there was significant chest wall recession. This is a very small baby, 26 weeks. Though there was adequate steroids, the baby is manifesting respiratory distress. So it depends on your unit policy. You can either intubate such babies and give surfactant because it's a very premature baby, or you can consider NIPPV and transfer the baby to the NICU and just reassess there. If oxygen requirement is worsening, you can give surfactant. Again, whether you give Ensure or not, we will discuss in the later discussions as well. So this baby received a 120 milligram curacao BT tube, and baby was continued to transfer to the NICU, ventilated in this case, not Ensure. Baby was having BT tube in situ. One of the critical concepts in managing a very small premature baby is what is called the golden hour approach to management. So critical period when if you do everything well, it makes a huge difference to the outcome of the baby. And if there are mistakes, again, it impacts these babies in a big way. For example, if there is temperature instability, if there is infection, if there is hypotension, the baby gets something like IVH, which has a permanent impact. And hypotension can also increase the risk of PVL, which is periventricular leukomalacia. So the neurodevelopmental outcome of this baby will become poor just because you didn't manage the golden hour appropriately. So we have a few points to remember. Thermoregulation. So the small babies, your labor room and OT temperature should be kept at 24 to 26 degrees. You be prepared with plastic bag. If you have the ability to have an exothermic mattress, you bring it as well. The warmer should be on and a trained team should be there. It's very important that we have a team who can manage such babies. If you are a new team, you try to expose them to a busy unit by allotting them time. And if you discuss within the team, have skill drills on how you approach an extreme preterm delivery, it will help out, improve as well. And the respiratory care, timely CPAP, timely pressure regulation. You don't use high pressures. Consider surfactant early and consider Ensure if appropriate or intubate. So avoiding hypo and hypercapnia, avoiding overventilation, avoiding hyperoxia or hypoxia, all of these are important. Infection prevention goes without saying because these tiny babies have very poor immune system. And unless you prevent infection, it's very difficult to treat once sepsis gets in. We have something called IVH prevention bundles, which incorporate the first 3 days of care for the small babies, right from preventing hypocapnia, positioning the baby not to overextend the neck, just keeping them on the back, not to put them on the side, gentle suctioning, gentle handling, avoiding unnecessary handling. Even brain scans are not done in the first 3 days, and so on. So this helps to prevent IVH, and you have to introduce that bundle and train your team in that. Delayed cot clamping is another very important intervention which prevents IVH or reduces the risk. And of course, IV fluid management, hypoglycemia prevention, these come into the golden hour as well. In the respiratory care, some units consider caffeine as part of the golden hour treatment, especially if you're trying to keep the very extreme premature babies on non-invasive ventilation. So the earlier you get caffeine into their system, the more likely you are to succeed with non-invasive and not intubate such babies for apnea, for example. So this is a type of transport incubator which includes a ventilator. You can connect fluids and shift the baby to the NICU in a safe manner. This can be used in ambulances as well. If you want to transfer the baby to a unit which can manage such babies, you can do that as well. A quick mention of surfactant, which we will discuss again in the next lecture as well. So I will be brief. The preterm lung is surfactant deficient, and the most common reason for respiratory distress in such babies is RDS, which is due to surfactant deficiency lung disease. Surfactant therapy was experimentally introduced in the late 1980s, and it became routine in the mid to late 1990s. We had synthetic and natural, but now we have only the natural surfactants. The most important ones are porcine curacao for bovine, and I think there is one more in India which is available. Most of the current recommendations suggest surfactant replacement is given as an early rescue. Previously, we used to give prophylactic surfactant for babies under 28 weeks. But evidence has shown that some of these babies may avoid intubation if you manage non-invasive ventilation appropriately. So if your baby needs intubation in the labor room, you give surfactant immediately for such babies. But if baby is managing on non-invasive, you consider early rescue depending on the FaO2. If it's more than 30-35%, The smaller the baby, you can use a higher threshold, 40% for the bigger babies and 30% for the smallest babies. Even when you need surfactant, it doesn't mean you need to keep the baby intubated and exposed to pressures through the ventilator. There is more studies coming up which show non-invasive surfactant therapy with either Insure or LISA are preferred. Insure, the concept is changing. Previously, we used to say keep them intubated for 2 hours, up to 2 hours, but now Insure is almost the same as LISA with using an ET tube instead of the LISA catheter. So you use the ET tube, which is the smallest size, intubate, give surfactant and remove. And with the availability of RAM cannula and similar options to give high flow or CPAP through the nose, without the need for this setup of CPAP hat and everything, we can keep the CPAP continuing even while you are intubating such babies with a nasal cannula. So the CPAP of 6 centimeter and FiO2 rising, then it's an indication for surfactant. Curasaf is preferable because it's a lower volume, and it comes as 1.25 and 2.5 ml. If you give Survanta, it's 4 ml per kilogram. And surfactant improves survival and reduces complications like air leak or IVH. So this baby has been given surfactant and is peaceful intubated. Some of you may have seen the devices used to fix the ET tube. This one is a tape. Preferably if you have a device meant to fix it, it's better like NeoBar or NeoFit. The chest X-ray is severe RD, as you can see, bilateral whiteout or ground glass opacity, some air bronchograms, but because it's whiteout, even the air bronchogram isn't that prominent. You can see the umbilical venous line, which is going up here, and the umbilical arterial line, which is looping down and coming up. And we have the feeding tube, the ET tube as well. So the baby is initially stable on ventilation and UAC, UVC inserted. The main advantage of umbilical arterial catheter is that you can use invasive blood pressure monitor, and in the tiny babies, it's very difficult to sample them. So it's a big boon to have a UAC in the first week when you do frequent blood gas analysis as well as monitoring of their electrolytes and infection status. So if you don't have a UAC, it's very difficult to save a 23, 24 weeker. About 25, 26 weeks, we try to avoid the UAC unless it's essential. And UVC is used in the first few days because majority of these babies need TPN. And if you fail in the UVC, sometimes the UVC goes in a different route. It doesn't go into the IVC. And you try again, you don't succeed, you may put a PICC line in the beginning. Otherwise, you see how the baby is tolerating feeds and then either replace the UVC with a PICC line, or if you're almost reaching full feeds, we keep the UVC up to 10 days and remove it directly when we reach full feeds. All the premature babies are nursed in an incubator with high humidity, which helps to reduce insensible water loss. The baby was started on ampicillin gentamicin, which is the first line antibiotics in most of the units. Of course, we tried to limit the exposure, so no need to give it for 5 days. Just keep it for 24 to 48 hours. Once you have the 24-hour inflammatory marker negative and the culture comes negative, you stop the antibiotics. Most of the microbiology labs can give the BACTEC-based culture reports by even 24 hours. And the baby received caffeine for apnea of prematurity as well. So apnea of prematurity is typically seen after 24 to 72 hours. There is cessation of breathing for over 20 seconds, or it may be for a shorter duration, but associated with bradycardia or desaturation. And it's mainly related to immaturity of the respiratory center. There is also a higher threshold for CO2 response. Suppose a baby is holding the breath and the CO2 starts rising, that triggers your respiratory effort. But in this case, the threshold is higher, so the baby holds for a longer time. And in that time, the FRC may drop, the lung may close down because the lung is not normal, and you may become desaturated. The oxygen may drop. There is also a paradoxical response to hypoxia in the premature baby. Suppose we stop breathing and we become hypoxic, we tend to breathe fast again. But in a premature baby, if there is hypoxia for any reason, they stop breathing for a brief time. So this causes apnea as well. And we have chest wall reflexes like Herring-Brewer, the stretched reflexes in the airway. Pharyngeal hypotonia plays a role as well in obstructive apnea and reflex laryngospasm, because these babies have higher risk of gastroesophageal reflux, and the reflexing contents can hit the airway. There is a reflex laryngospasm, which again leads to the cycle I told you of lung going below closing volume, FRC dropping, hypoxia. And hypoxia itself may cause more hypotonia. So everything may aggravate. We have three types: central apnea, obstructive apnea, and mixed apnea. Central apnea and obstructive apnea are common. So most of the apneas tend to be mixed because one leads to the other. If there is central apnea with hypoxia, which causes hypotonia, the airway obstruction follows. If it's an obstructive apnea and it leads to hypoxia, this hypoxic central response takes over and it becomes a central component as well. The baby stops breathing. Initially, they continue breathing if it's obstructive apnea, but the airflow is not adequate. Apnea of prematurity is a diagnosis of exclusion. If it doesn't follow the typical pattern, you need to look for secondary causes like worsening lung disease, sepsis, electrolyte imbalance, and so on. So hypocalcemia can cause, even if temperature instability, if the baby is overheated, they are at higher risk of apnea. If they're hypothermic as well, they may go apneic. Polycythemia is a known factor as well. So we use caffeine to prevent and manage apnea. And if there is persistent apnea, you use non-invasive ventilation to try and maintain the FRC. However, if it's more advanced, you may need to intubate and ventilate the baby. However, intubation ventilation is more likely to be needed if there is secondary apnea due to worsening lung disease, sepsis, and so on. So we have prematurity as a main factor. The central response is different. Inhibitory reflexes, CNS pathology, meningitis or IVH can lead to apnea. Infection in many ways, including the cytokine response, stiff lungs, and so on, can lead to apnea. Impaired oxygenation due to whatever reason through the prematurity and the hypoxia-related response. And metabolic disorders, hypocalcemia especially, can lead to apnea as well. And hypoglycemia can present as apnea. So this is the three different types. In obstructive apnea, you have a normal breathing pattern. Suddenly the airflow stops, though the thoracic movement is maintained because there is some obstruction. The oxygen saturation drops here. In central apnea, the baby stops breathing, there is no airflow and the oxygen drops. And in mixed apnea, you may have either of the two patterns, either it starts as central and becomes mixed, or it may be starting as an obstructive and due to the hypoxia, it becomes central. So in this case, at 4 hours of age, there was a sudden desaturation with a drop in blood pressure. The ET tube was in position. There was no evidence of a tube block. There was reduced air entry on the left, and there was a raised PCO2 on the blood gas. So an urgent chest X-ray was requested and transillumination was performed. So a left pneumothorax was diagnosed on cold light, and the chest X-ray which came immediately confirmed the same. So a pigtail chest drain was inserted and the air leak was drained. And when a large air leak is drained, we connect it to negative section of -10 to -15. And with the drainage, the ventilatory requirement stabilized, the BP was stable. So this is the left pneumothorax. Mediastinum is shifted. You obviously have the history of the blood pressure dropping. The collapsed lung can be seen very well. So this is obviously a tension pneumothorax. This is a pigtail catheter. We have the standard Procar as well. If it's a larger baby and you want to try needling first, you may be able to avoid a chest drain insertion if the baby responds to just needling. But in a smaller premature baby who is ventilated, you would keep a chest drain. And these are gentle material, silicone material, which coils up. The tip is very soft. And you insert it like a semi-Seldinger technique. So you have a guide wire and you thread this on top of it. Moving on to cranial ultrasound monitoring. So in a premature baby, there is a risk of intraventricular hemorrhage, and later on there is a risk of PVL. So regular cranial ultrasound monitoring is recommended for all babies at or below 32 weeks. And for more mature babies with severe IUGR, if there are neurologic concerns for any reason or a complicated course, you would do cranial ultrasound as well. MRI is better than cranial ultrasound for babies with brain pathology. So you do the ultrasound first, but if the baby continues to be neurologically abnormal or if the ultrasound shows findings, you better go for MRI, especially in term babies with asphyxia or a stroke-like insult. In majority of the babies, we avoid the scan nowadays the first 3 days and do by first 3 to 5 days. And later you repeat depending on the findings. So in a 32-weeker, you may just repeat one scan and discharge. In a more premature baby, you continue checking every few days. If there was an IVH of grade 1 to 4, if it's an IVH of grade 3 to 4, you would repeat it more quickly to monitor the progress. And some of these babies get obstructive hydrocephalus. So we need to monitor the scans 1 to 2 weekly according to the nature of the problem. The late changes you find on the scan is cystic PVL. So this is the description of the papal staging of IVH. Grade 1 is restricted to the subependymal region or the geminal matrix, which is seen in the lateral view in the chordothalamic groove. A grade 2 is extension into normal sized ventricles and typically filling less than 50%. A grade 3 is extension into dilated ventricles, filling more than 50%. A grade 4 is usually parenchymal extension in addition to a grade 3 bleed. Sometimes you get isolated parenchymal bleeds, which will be separate. But a grade 4 IVH needs bleeding into the ventricles with dilatation as well as periventricular hemorrhagic infarction, which is basically the dilated ventricles obstructing the venous return from the cortex, and there is periventricular hemorrhagic infarction of the brain tissue. So that becomes a wedge-shaped infarct, and that looks like a bright echogenic mass. Most of these babies, the PVHL heals by cyst formation. So it becomes a large cystic porencephalic cyst. In this baby, there was a grade 2 hemorrhage and further scanning was continued as planned. So in this, after the pneumothorax, the chest drain was clamped and removed, and express breast milk was gradually introduced by nasogastric feeds. Normally you would start earlier, but because of this unstable course with the pneumothorax, it was delayed. Even if the baby is sick, you can give something called trophic feeds. We will be discussing one lecture on enteral feeding of premature babies, so we'll discuss in detail there. Baby had a repeat cranial ultrasound once the pneumothorax resolved and it was stable. Antibiotics were discontinued after negative blood cultures, and the baby was extubated to nasal CPAP by day 5. If not for the pneumothorax, this baby would have been extubated by the first day itself. So it's very important to have a standardized feeding protocol for the premature babies. We start with trophic feeds, and EBM is definitely preferred. It's very important to prime the mother from the beginning and start expressing within the first hour after birth, which increases the chances of successfully getting enough EBM. So the initiation is done if baby is medically stable in the first 24 hours. Advancement 10 to 20 is a standard for the extreme premature, but for the bigger premature, you can go up to 30 ml per kilo. And the maintenance should be to maintain a weight gain of 50 to 20 grams per day. And human milk is the best source. We tend to avoid looking at regular residuals, but if you have more than 50% residuals, you may need to reduce the feed intake or hold and assess the baby. And preferably, we use orogastric tube in the below 32 weeks because most of these babies are on non-invasive ventilation through the nose. After the baby stops non-invasive, you can use nasogastric tube. So this is the baby peacefully on nasal CPAP. We'll be discussing ventilation later on, but non-invasive ventilation is preferred in most cases because it avoids intubation and the complications related to mechanical ventilation. So lower risk of BPD and complications like ventilator-associated pneumonia is definitely shown with non-invasive ventilation. We have different forms: high-flow nasal cannula, humidified high-flow nasal cannula, CPAP, NIPPV, which is like a higher form of CPAP, non-invasive positive pressure ventilation. And we always use blended gas. So whenever you ventilate the baby, either invasively or non-invasively, never use just oxygen because there is a high risk of ROP. And it's a huge medico-legal problem if you get ROP and you didn't use appropriate ventilation, like mainly the blender is important. FiO2 should be controlled to the lowest possible. You monitor the saturation and keep the target limits. There is a risk of oxygen toxicity at ROP if you don't titrate it. We need very good nursing care and appropriate interface. You may rotate the mask and prong, for example. Humidification is very important because the baby cannot get the cold, dry air. In a non-invasively ventilated baby, the gas flow is fast for the baby's own mechanism to humidify. And these babies are already cold stressed. They are small babies, so you need to humidify and heat the gas. There is a concept of adequate FRC. So it's very important to recruit and maintain the lung volume in these babies to prevent worsening. So if there is any event like an apnea which drops your lung volume, you recruit the lung by increasing the pressure for a brief time. So this baby by day 10 reached full feeds, had the umbilical lines removed, and was on nasal CPAP. Because the baby reached full feeds by day 10, there was no PICC line inserted. By day 15, there was episode of apnea, reduced activity, and feed intolerance. So the most important differential diagnosis at this stage is sepsis because the baby had central lines and was unwell. So there is also a possibility of necrotizing enterocolitis because the baby was on full feeds, and by day 15, baby started developing feed intolerance. The CRP was high, 105. The CSF was done because the late onset sepsis, CSF is indicated. It was not suggestive of meningitis. The baby was started on vancomycin and gentamicin. We need to go for the second line antibiotics. In developing countries, you may go for vancomycin and meropenem if ESBL risk is very high. Vancomycin is important because coagulase negative staph is a common cause of sepsis when you have lines for a long time, and it's usually methicillin resistant as well. The abdominal X-ray was suggestive of stage 2 NEC. The baby was kept off feeds and the long line was inserted. Baby was started on TPN and lipids again. Needed reventilation because of recurrent apnea and NEC. So in NEC, you don't want to go high on non-invasive settings because the gut is already compromised and you don't want the gaseous distension. So this is one condition where you may intubate to protect the gut and the baby to get rest. The blood culture grew coagulase negative staph. As expected, it was sensitive to vancomycin. So this is not the cause of the NEC, but it's an associated infection which can compromise the baby. So we have the tram tracking appearance, the nematosis intestinalis, which is typically the picture seen in stage 2 NEC. So necrotizing enterocolitis is acute and potentially serious gut condition which affects mainly the premature babies. It can be seen in some term babies, especially those who are exposed to hypoxia, ischemia. Remember, this can happen within the uterine stay as well. So the baby may become symptomatic even within a few days of birth if it happens in a term baby, because ischemic injury is either at or before birth. In a premature baby, the timing is according to the gestational age. The more premature the baby, the later the onset. If it's a 24-25 weeker, we expect after 3 weeks. If it's a 32 weeker, it might happen by 10 to 14 days. The feeding pattern is important. How successful we were, whether we had EBM, severity of the underlying conditions. So this baby had a tension pneumothorax, which could have led to a hypotensive insult. The baby had sepsis as well. If you don't give EBM or you're adding human milk fortifier, which increases the osmolarity of the feeds, it might contribute. Antenatal steroids are protective, as we discussed earlier. This we discussed already. The management is by keeping the baby off the feeds, giving TPN during that period, antibiotics as appropriate and titrate it, rationalize it according to your culture reports, surgical intervention as appropriate as well. So if it is a severe NEC with fixed bowel loop, perforation and so on, laparotomy with exploration is important. Some of these babies are very tiny, they are very poor risk for surgery. And in that case, the surgeon may decide to put a simple drain and review. These babies may still need laparotomy once the baby is clinically more stable. We have something called the Bell staging or modified Bell staging for NEC. So stage 1 is suspected NEC. Most of the epidemiologic data now don't include stage 1 because it's very non-specific, and this feature can be present with any deterioration, sepsis, for example. If there is bloody stool, it goes more in favor of NEC. And on X-ray, you may find dilatation, non-specific dilatation and mild ileus. Again, ileus could happen with sepsis as well. Stage 2 is proven neck, and we have the stage 1 findings plus metabolic acidosis, thrombocytopenia. The bowel becomes sluggish, and there may be abdominal tenderness and redness of the abdominal wall. We get intestinal dilatation, ileus, nematosis intestinalis, and portal venous gas. Previously, we used to say 2A, 2B, and same with stage 3, which is advanced NEC. We have severe apnea, hypotension and shock, DIC, neutropenia. So stage 3 neck has a very high mortality rate, and we get ascites and pneumoperitoneum as well in these cases. So most of the stage 3 either need drain or laparotomy, and stage 2 you need to monitor them closely and treat appropriately so they don't go into stage 3. We have something called fulminant neck, where within a period of 12 to 24 hours, the baby starts getting rapid abdominal distension, typical nematosis, and goes into shock. So before we can do anything, baby passes away. So the CRP responded to the treatment and improved to less than 6 by day 6. The day 5 X-ray was normal and the feeds were gradually reintroduced. If you don't have EBM, you might consider starting these babies on amino acid formula or elementary formula till they are tolerating the feeds. Donor breast milk is an option as well. Antibiotics are given for a 10-day course in this case, and there was a negative blood culture repeated on day 4 of the episode. Baby established full feeds and tolerated well. The baby weaned off CPAP to high flow nasal cannula on day 18. It came off high flow on day 42 to low flow nasal cannula because the baby had BPD. This is the only setting where we use low flow nasal cannula. There is no distress, the baby doesn't need pressure, but just needs a little bit of oxygen, so you can go. But otherwise, where you need pressure, stick with high flow nasal cannula. The baby came off low flow at 40 weeks. So the baby qualifies for a diagnosis of bronchopulmonary dysplasia, which used to be called chronic lung disease of prematurity. So BPD is where the severity varies, and where the baby is oxygen dependent or ventilated at 28 days, it's mild. Where the FiO2 is less than 0.3 at 36 weeks, it's moderate. And the baby is oxygen dependent with the FiO2 more than 0.3 or needing non-invasive ventilation or invasive ventilation at 36 weeks, that's severe. Some of these babies need oxygen at home if you can arrange it, otherwise they stay in hospital for a long time. There is a severe risk of PPHN in the long-term BPD babies, the severe ones. So it's very important to do echo from 36 weeks onwards if the baby has more than 0.3 FiO2 or continues to need ventilatory support. And you repeat the echo even if there is no PPHN at that stage, you repeat it every 2 to 4 weeks. And RSV infection is a bad prognosis in these babies, so you consider Synagis, which is the RSV immunoprophylaxis. The baby had neonatal jaundice. I didn't focus on that. We will have a separate lecture on jaundice. Anemia is fairly common, partly because these babies have low blood volume. If you don't do delayed cord clamping, you repeatedly sample these babies in the first week and their hemoglobin drops. The babies don't produce their own red cells for 6 to 8 weeks in the premature babies and 3 months in term babies. So if you lose blood, it's not going to be replaced unless you transfuse. Osteopenia of prematurity is a high risk, but nowadays with appropriate TPN, we can minimize. You monitor for it by 3 to 4 weeks in the babies below 30 weeks. Calcium, phosphate, vitamin D replacements may be needed. And ROP was monitored. This baby had stage 2 pre-threshold, but resolved without treatment. ROP is nothing but abnormal vascular proliferation in immature retina. Its pathophysiology involves vascular endothelial growth factor or VEGF. So there is exposure to excess oxygen in the beginning. There is immature retina in the background. The fluctuating PaO2 related to lack of titration of your oxygenation and ventilation may matter. When you give blood transfusion for a baby, you're replacing hemoglobin F with hemoglobin A2 or A, and this releases oxygen more easily to the tissues, and you have a higher risk of this. And that increases the risk of ROP as well. And sepsis, the cytokine response, and so on, increases the risk. So screening for ROP, the criteria are different in the developing countries and the developed world. In developing countries like India, the NNF has come up, for example, with recommendation for all babies less than 34 weeks and less than 2 kilo, which is a huge number, and it was increased in the width because of a high risk of accelerated posterior ROP, aggressive posterior ROP, and careless use of oxygen, not using the blender appropriately plays a big role as well. So in the developing countries, the developed world, it's less than 32 weeks and less than 1.5 kilos. Screening typically starts by 3 to 4 weeks of age, and it's done 1 to 2 weekly till the vascular maturation is complete. So the ophthalmologist has to confirm that the vascular maturation is complete, or if there was ROP, they have to see that it's regressing. And this I stressed already, don't give positive pressure ventilation, either invasive or non-invasive, right from the labor room without the use of a blender. Because you have very poor options. Nowadays, there are cheaper blenders. They may not be the best because you can't titrate exactly, but at least you can keep them within ranges of, say, below 40%, 40 to 60%, 80 to 100, and so on. So at least you are able to titrate to a reasonable degree. And in ROP, you may need treatment with anti-VEGF injection to stabilize and laser treatment if they have gone to aggressive stages of ROP. So we have stages of ROP and zones involved. So we have first stage, which is demarcation line alone. Stage 2 is formation of a ridge. Stage 3 is ridge with extraretinal fibrovascular proliferation. And in stage 4, you get a subtotal retinal detachment, which is quite serious. And anything from stage 3 onwards, especially if it affects the central zone 1, becomes a candidate for treatment. If the baby is very small and it's still progressing, you may consider the anti-VEGF injections, which are now available. It's given into the vitreous. It can be done in the NICU itself. And it's quite expensive, and it's not a permanent treatment. You may still need laser in these babies. So the zone 3 is a peripheral zone, and zone 1 is a central zone. This is the macula and the optic nerve. So anywhere in the zone 1, it's a high risk of total blindness. So you have to be aggressive with the treatment. The stages we already discussed in the earlier slide. So the demarcation line, demarcation ridge, proliferation, and this is a detached retina, which is a very poor prognosis. So another view of the same issue. You are not going to allow the stage 3 onwards if possible. Plus disease is where there is a huge vascular proliferation. The ophthalmologist can see dilated tortuous vessels, hazy vitreous, and that indicates the disease is active, and that becomes a criteria as well. So if you have a certain zone involvement and a certain stage, with or without plus disease makes a difference to the approach as well. How quickly you review depends on that as well. So you may decide to review in 5 to 7 days if it's aggressive disease. You may wait up to 2 weeks before the next review if it appears to be quietening. So the vaccination in the premature babies is usually given by the normal age, not by the corrected age. The concept of corrected age is removing the, post-conceptional age, we call it. So we have gestational age, which is the actual maturity or the post-conceptional age. The premature baby who is born at 28 weeks or 26 weeks, by the time he is 4 weeks old, his post-conceptional age is 30 weeks. Once they cross full term, we call it corrected gestational age. So when they reach 40 weeks, it's called term plus the corrected age. So this baby becomes post-conceptional age according to the prematurity. You have to correct a 40 when the premature baby reaches 40 weeks, it's a term corrected age. So you understand that. And then when the baby reaches 2 months post-term, that's instead of you remove 3 months from a 26-weeker, you remove 2 months from a 30-weeker and so on. This correction for prematurity, when the baby reaches 2 months post-term, you make them term. This is used for both developmental milestones and growth monitoring, but for vaccines and for feeding, it's not considered. You use the chronological age. It's very important to train the parents in resuscitation training, because even though the premature baby is bigger when they go home, they have a higher risk of reflux and complications related to choking on their feeds, and they need to be capable of calling the ambulance as well. Very important to follow these babies in the neurodevelopment assessment clinic. There is something called early intervention therapy, where if you find any high risk factors or if there is any scan abnormalities, if the baby has ROP and BPD and all, physiotherapy, occupational therapy, and multidisciplinary input is there to try and help them progress to the normal development.